Dear Dr. Hilveno Corsiga, dear colleagues, it is a great honor to speak on your mid-year convention. Therefore, I cordially thank Dr. Vanni Christie for the invitation. My name is Björn Hossfeld, and I am a senior consultant in the Department of Anesthesia, Intensive Care Medicine, Emergency Medicine, and Pain Therapy at the Military Hospital Ulm in southern Germany. This hospital serves as a level 1 trauma center, and in cooperation with the German Automobile Club, ADAC, we run the helicopter emergency medical service for the region around the world's highest steeple. I was asked to speak about airway management outside the OR, and as our department is responsible for anesthesia, intensive care, the emergency department, and the pre-hospital EMS, I'd like to give you an impression of our experience. In the operations theater, we experience a rare number of difficult airways, which are managed by experienced teams consisting of physicians and nurses specialized in anesthesia with a lot of routine in their jobs, who in case of any difficulty can rely on a senior consultant as backup. The patients are fasting, well known prior to induction, and in most of the cases, physiologically stable. They are bedded in optimal position on the OR stretcher, accessible 360 degrees around them. In the rare case that laryngoscopy does not work, a bunch of trained alternatives are available. So the three factors, team, patient, and device, are optimal. If we leave the OR just to the ICU, we meet a team highly experienced in critical care, but airway management is not their daily business. Patients are often physiologically compromised, and intubation is the last resort following other attempts like non-invasive ventilation. The access behind the patient's head is often restricted by a lot of devices like syringe pumps, monitor, or ventilator. If we leave the hospital and go to the EMS system, we often meet less experienced teams. The assistance is not as highly specialized as with an anesthesia nurse. And the physicians do not have any backup. There is no senior consultant on scene. The patients are not fasting anymore, and they are mostly physiologically compromised. The access is restricted often by the patient's position, lying either somewhere on the roadside or on stairs or somewhere between the bath tube and a cupboard in a narrow bathroom. And supraglottic airway devices and cricothyrotomy are the only alternatives provided in the out-of-hospital setting. So things becoming worse as far we leave the OR. Physiological dearrangements are very well studied. Especially in the pre-hospital setting, there is a limited ability to tolerate prolonged intubation attempts, and we see hypoxemia in 10 to 20% in Europe, and in one old paper from Danforth from Southern California, in more than half of the patients. In a very big emergency department in Phoenix, Arizona, John Seckles and colleagues studied adverse events during emergency airway management, and they found that there are adverse events in 14% of all cases when the airway management is successful on the first attempt. But there is an increase in adverse events to 47% if just a second airway attempt is necessary. From such results, Bill Hinckley named a slogan -1A, definitive airway sans hypoxia on the first attempt, which is very good promoted by colleagues like Scott Weingart in some very good lectures, also from John Seckles or from the British Society. So there is a great importance of first pass success, especially in anesthesia in emergency cases. And there are some papers showing that we can optimize this first pass success by using video laryngoscopes. If you look to the picture or to the screen of the video laryngoscope used in the picture, then you can imagine that it's much more easier to intubate a patient with such an excellent view. But if you look closer to the question whether a video laryngoscope will help you or not, I must say it takes more than video laryngoscopy for successful airway management. Just to compare two papers, the one on the left-hand side, published by Griesdale and colleagues in the Canadian Journal of Anesthesia, and on the right-hand side by Silverberg and colleagues in the Critical Care Medicine. Both study groups compared using video laryngoscopy or a standard Macintosh plate. And the one group found there's no difference in first pass success, while the other group found a significant difference in first pass success. So with these competing results, we have to look closer to the studies and to the analysis. Both groups used GlideScope, and both groups excluded patients with anticipated difficult airway from their study, which from my point of view is very interesting because we like to use the video laryngoscope especially for difficult airways. In both study groups, the operators were less experienced residents. The interesting thing is, while Griesdale, who found no difference in first pass success, used neuromuscular blocking agents in all of the patients, the study group around Silverberg, who found a significant difference in first pass success, did not use neuromuscular blocking agents at all. And to be honest, the first pass success was low in both groups. So it's not enough to use a video laryngoscope to be successful in emergency airway management. You also need to have a right concept. It's very important to have an idea what you like to do with this special patient. You have to communicate your idea with the whole team, because especially in the pre-hospital or out-of-hospital setting, the team is not as routine as the team you know from the OR anesthesia. As the patients are mostly compromised with their physiology, you need time for pre-oxygenation. Then, before using any induction of anesthesia, You should think about stabilization because patients are already hypotensive, for example, and then you should very wisely choose your medication. And there are special factors to the team outside the hospital. There is a wide range of qualifications outside the OR, and there is far more experience on the intensive care unit or in the emergency department compared to the pre-hospital setting. But especially in the pre-hospital setting, the difficult airway has to be more expected than in hospital. And the guidelines, the international guidelines for out-of-hospital airway management recommend a in-hospital training. And the benefits of such training has already been demonstrated by different colleagues, like Michael Gallafors from Sweden. So if there are differences in the qualification of the operator, it's very necessary to get the right operator in the pre-hospital setting. There's one paper from Jan Breckwold who compared a physician or two physician staffed ambulance cars in the area of Berlin. And he had very experienced emergency physicians on both cars. But on the one car, the emergency physicians were originally trained in internal medicine. And as they were well experienced in internal medicine and well experienced in the EMS system, he called them the proficient performers. But on the second car, he had EMS physicians trained originally in anesthesia. So he decided that as they are from anesthesia, they are as proficient as the other colleagues, but especially in airway management, those are the experts. So he compared these two groups and found the following differences. The experts, so the anesthesia-trained colleagues, used 4 times more a optimizing of the patient position before starting the induction of anesthesia. The experts use double as often neuromuscular blocking agents in the pre-hospital setting. The experts use double as often a external manipulation of the larynx. And with these measurements, the experts received a Cormack and Lehane grade 1 with their laryngoscopy in 50% more of the cases. But interestingly, there was no significant difference in their first pass success of both groups. Now it's the year 2021, and Ron Walls from a big emergency department in Boston stated 9 years ago that it would be wrong to practice direct laryngoscopy in emergencies. As I showed before, if we have a close look to the screen of the video laryngoscope, it seems to be clear why it is helpful to use such a device. But we have to look much closer to the different video laryngoscopes and their help for success. So Lewis and colleagues did a systematic Cochrane review to decide whether video laryngoscopy or direct laryngoscopy is a benefit for tracheal intubation in adults. And Lewis could show that using a video laryngoscope provides a better view according to Cormack and Lehane. And also he could show that using a video laryngoscope will reduce the risk of esophageal intubations. But he also stated that a video laryngoscope used by unroutine providers will not improve the intubation success. And he could show with his Cochrane review that there was no improvement if the video laryngoscope was a GlideScope Series 5, a Pentax Airways, was a GlideScope, a Pentax Airway Scope, or a McGrath Series 5. But he could show an improvement with a CMAC by the company of Stotz. So what is the difference in those devices? A Cochrane review is not done to do any company bashing. So there must be a other difference in the video laryngoscopes, and it is necessary to use the right tools for airway management. But the question is, what are those right tools? Because the market of video laryngoscopes is growing every month. And this is just a short impression of the devices provided by the market. We all come from direct laryngoscopy. We are trained to use Macintosh plates to perform laryngoscopy and to intubate our patients. Now we should deal with video laryngoscopes. And so we have to have a closer look on the different blade sizes and shapes. So there are video laryngoscopes using Macintosh-like plates, not only Macintosh plates, sometimes there are only Macintosh-like plates, but there are many video laryngoscopes using hyperangulated plates. And Tim Cook and Fiona Kelly stated that a good video laryngoscopic view does not guarantee easy intubation. And it's obvious that we have a better video laryngoscopic view with a hyperangulated plate because we just look around the corner. But if we look around the corner, we have to place our tube also around the corner, and this might be more difficult. So from our point of view, we decided to use a CMAC because the CMAC offers different plate sizes and shapes, and by relying on a Macintosh plate, it combines both the direct and the video laryngoscopy. In this slide, I've tried to compare the blade shapes. Above you can see a hyperangulated plate provided by the company of Stott. It's called D-plate, and this is a really hyperangulated plate which offers the chance to look again around the corner, but there's no chance, if you see the red line, to have a direct view to the vocal cords. If you use your video laryngoscope with a Macintosh plate, like shown below, the Macintosh plate provides both the same video laryngoscopic view with the angle of a
around 60 degrees as the hyperangulated blade, but also the chance to use this laryngoscope as a direct laryngoscope in case that the camera of your blade is blurred by debris or blood or vomit or whatever. So our suggestion is to use Macintosh-like blades. This gives us the chance to do videolaryngoscopy to facilitate intubation. And in case of any problem with the camera or the video screen or whatever, you got the chance to do or perform direct laryngoscopy. So I'd like to give you an impression of the daily routine in our hospital or in our department. We use a videolaryngoscope in the OR for any anticipated difficult airway that allow us to train our colleagues. And we use a videolaryngoscope with a Macintosh-shaped blade for the training of our novices. So this allows direct laryngoscopy for the trainee. So he has to use the direct view to the vocal cords, while the teacher can use the monitor to give hints and control the action. We use a videolaryngoscope for every intubation out of the OR, because we think that intubations or airway management out of the OR are performed in emergency, or at least under more stress than in the operating theater. So as well as in the emergency department, as well as in the ICU, we use a videolaryngoscope with a Macintosh blade as a standard for airway management. And we use a videolaryngoscope in every emergency inside and outside the hospital, so as well as on our helicopter emergency medical system. So if we use a videolaryngoscope as a first-line device, we try to optimize the situation to aim for a very high first-pass success. But even with using a videolaryngoscope, from time to time, we do not achieve first-pass success. So I'd like to introduce our algorithm for these cases. If the first intubation attempt fails, we may start to use a back valve mask ventilation, and if this works, we got enough time to optimize circumstances. And if circumstances are optimized, like positioning of the patient's head, bending of the tube, using a bougie for railroading the tube, or changing the size of the laryngoscope blade, we try to do a second attempt. If back valve mask will not work, we do not try a second attempt. We use a supraglottic airway device as a second alternative. And so we do if the second ETI attempt fails. If the ventilation is capable with a supraglottic airway device, then we are fine. But if in the rare case a supraglottic airway device will not work with the patient, we are in a cannot intubate, cannot oxygenate situation, and we have to perform surgical airway. So with this algorithm, we work in emergency airway management in hospital, in the emergency department, on the ICU, and in the out-of-hospital setting. And we always use a CMAC pocket monitor video laryngoscope as the first line device. As we do this since 2009, we studied our results. All physicians on our helicopter are board certified anesthesiologists, and since 2009, intubations are exclusively performed using a CMAC or later on a CMAC pocket monitor without any exception. And if we have a look on the figures, between 2009 and 2015, we performed this procedure in 766 cases. And I can tell you, we achieved a proper airway by intubation without using any alternatives in 100%. To be honest, in 90% we achieved a first pass success, and in another 8% we were successful on the second attempt, and in 2% we left, or not we, but the acting physicians left the algorithm and decided to do a third attempt by intubation on their own decision, and they were successful without using a supraglottic airway device or without having to perform surgical airway. Interestingly, we achieved a very good video laryngoscopic view. Using the CMAC video laryngoscope with a Macintosh blade on the first attempt, we achieved 95% Cormack and Lehane graded 1 and 2 patients. And just to compare this with our results before the introduction of the video laryngoscope to our HEM system, it is a significant improvement of about 10%. So, as a conclusion, I'd like to say airway management out of OR is more challenging than in the operating theater to a number of reasons, especially according to the team performance, to the patient requirements, and also to the devices we can use for alternative. We should aim to improve our first pass success, especially in emergency airway management, and therefore we need to have a concept for pre-oxygenation and good medication, including patient stabilization. And we always should use a video laryngoscope with a Macintosh blade as first line device. And even if we do so, we have to be routined, and we should be very skilled in the alternatives in case of laryngoscopy failure or intubation failure. So we also have to be routine with supraglottic airway device and surgical airway. Thank you very much.